Thank you, Venkatesh sir. If not for the Pondicherry days, I would not been into innovations inspired by you, sir. Thank you for this wonderful opportunity. So VR and AR and especially what's the way forward. So traditional ophthalmic teaching was all about Halstead's. Can I have a laser pointer, please? Yeah, laser pointer, please. Traditional ophthalmic surgeries were based on Halstead's methodology. It's intense and repetitive, where you have to, you are told that just keep repeating, and you'll be learning it soon. So performing surgeries, it was a predetermined number of procedures that you had to, keep pushing yourself. That's what it was told, and there is an inconsistent skill acquisition and risk of patient exposure to inexperienced surgeons were also there. So then came the practice of animal eyes, where it won't suit human tissue, no real tissue challenges, lack of fluidics, and there were some major limitations in them as well. So that's when I started venturing into virtual reality and augmented reality, and COVID also really helped me get this up and rolling. So can augmented reality enhance the precision in microscopic procedures? So this was another literature which paved a light called the CAT AR, the novel AR based stereoscopic, and which uses infrared optical system with two cameras, and this has been well published, and was one of the papers that struck to my mind. As you can see, it was a stereoscopic augmented reality system with dexterous instrument, and it really gave you a real world immersive experience of how things are. So this was one of the modules that I was also closely following, which had a good amount of accuracy and the sensitivity and specificity that a good simulator needs to have, especially a circular tracing and an anti-segment navigation. So this was my own concept called the IMG AR, where I tried to make a science fiction concept to a science-based reality one, where I started in a very simple way using the phone's LiDAR technology. So in the smartphone, when we take a selfie, we tend to have a hat or have a bunny ears. These were some of the things that our children used to play with. So what I used the similar technology called the LiDAR technology, and in this piece of paper, if you are going to throw your phone and switch on the application, you will get the holograms in the phone. So that was how it started for me. So we created an application where it detects this piece of paper and you would get the hologram. So that was how it started as a baby step, because for me the challenge was, can we make the phone itself into a table like thing where you can mount the phone and then get the eye as a hologram, where then play along with it with whatever instrumentation, or even to deviate a bit, the three-dimensional undissectable structures that we ophthalmologists don't get to do or don't get to see actually, even in dissection classes, the circle of Willis, the cavernous sinus. We always tend to imagine structures cognitively, and that's how we actually learned majority of ophthalmology, if you actually see. And then I started pushing into more practical scenarios, like hydro dissection versus a hydro delineation. Can we really show where we need to place the cannula? Because we all have mentors who draw on a piece of paper and tell us that this is the plane that you have done a dissection wrongly, and maybe this is where you might need to do, be it rexes or be it whatever. So this is the rexes that we have almost cracked it at our center. So these are some of the very exciting times, because this is another novel technique for posterior polar cataract. But the idea here, what I'm trying to say is, if a three-dimensional evaluation or a three-dimensional representation of a surgical procedure, be it a hydro dissection or a hydro delineation that you tend to do, which you always mentors, when you go back, your mentor draws on a piece of paper after a complicated OT, and you also try to imagine things in the OT field. You are on your own. You don't even get to know whether you are in the right plane or not, and you end up with making a complication, and different people will be having a different complication profile. So this is a first holographic eye model with true confocal images. You can see the fundus, and we used photoreal mirroring for the angles, and try to keep it as realistic as possible, and we evaluated it and published it widely in European journal as well as the Indian journal as well. So the model that I made, you can see on the left hand side, just a smartphone. You don't need those fancy simulative headsets or the gadgets. And you can see this paper. That was how I started. I'll be taking you through in the next 6 minutes as to where I am also now. So on day one, you can actually orient to the angle into the retina, undergraduates or postgraduates or a fellow or a retinal surgeon who's aspiring to be. You get to see, so on the right hand side is the mobile camera view, left hand side is what you see on a camera. And when you move your hands towards the paper, you enter into the fundus, or when you come out and when you move towards the angle. So you got this complete cognitive three-dimensional orientation just on a smartphone, an offline app, and cost effective. When I launched it, I did not even charge the app, and it's still free of cost. So these were the models that really started to make, because ophthalmology was needing more of neuro-ophthalmic touch as well, to deviate a bit here. So I brought in this subtractive learning. It works for other anterior segment surgeries too, where as I was moving towards, I realized that textbooks were giving more of what the author wanted you to see rather than what you want to see. So I added a button here that can we, give the author that he decides that I don't want this. Can you remove this? I don't want the brain, or I don't want the brainstem. So he is choosing what structures he wants to remove, and that way he decides what frame of choice he wants to see, rather than the author telling us what he wants us to see, rather than we giving the user the empowerment to actually go ahead. So just a bit deviation here, but I'll come back to the anterior segment and cataract surgery. The eyeball is here again. So these models were all made by myself. I had to do a lot of things I didn't like, especially reading Cunningham's, because I had to get the three-dimensional bending correctly, because there was not much of guidance when I referred books. There was not much of 3D oriented guidance. So I remember 1.5 to 2 years, I was just past anatomy. If not, I would have failed also in first year. My dad was also very worried about my anatomy results more than anything. So you can see again the angles here, the angle recess, everything we were able to make exactly how a neophyte would want to see. This is again a brain model of the sulci and gyri that I made, on the right hand side. Yes. And just a bit of, and this was one simulator in smartphone which I am very fond of even today, which is a simple direct ophthalmoscope. So nowadays when my postgraduates come to me, I don't speak to them. I just open this and I give the phone in the hand, and I tell them to move into the pupillary area like this. So they move into the pupillary area, and they go into the fundus like this. So doesn't it make it very interesting? So they know how they need to do a direct ophthalmoscopy, front, back. They go front and back, and I immediately pass the phone from the right hand to the left hand, so that they get their left hand orientation. Otherwise, most of the surgeons, or they tend to hold the 90D or 20D only in the right hand for both eyes, and it is very disturbing for the patients. I always feel right eye you need to use your left, and for left eye you need to use your right. So ambidextrity training also was very important facet, and this was a whole high, and this is my own model, and we are still working on it to evolve it better. And this is another anterior segment simulator which we recently cracked, and another patent which I recently filed. So this is like the Johnny Quest. The millennials will know what is Johnny Quest. Once you wear it, see how your hands are looking. Real time, this is how your hands will look. It look like as if a binary code is there, and you take a mix injector and you go into the angle, not once but twice but multiple n number of times. You can go and place the stent, which the company doesn't give you more than 1 or 2 times, and you may sometimes even not get a model also. So once you place it in the right plane, you can go back to your surgery, and you can master the art of microscopic surgeries. These are surgeries which are very demanding, especially on a scale of minimally invasive phenomenon. These are things to simulate real world experience, and the principles are, these are the 4, my dear friends: pre-reading, assessment, instructor-led training, supervised practice, and simulator supported learning. And for me it was always this movie was the one which got me going, because I really thought, can I do this? And when I told to my friends or my father, he just told me, you go to the OT and operate 100 cases a day. That's what we do as ophthalmologists. So then, but I had my own way, and this is my recent simulator module that I am working on. It's a trainee interference VR learning loop, where I am trying to work on the difference between a vertical chop versus a horizontal chop. So can I work on a simulator which this is a vertical chop that I am currently working on, and this is an horizontal chop. And my idea is to bring it economical. So all the innovations that I have made, I have not charged it, or rather it's actually free of cost. And I also feel for completion for the next minute, IC is there, Phacovision is there. These are not mine, but I just thought I should, just show certain videos for the benefit of my fellow colleagues and novices in the group. So these are some of the simulators you can go, and these are widely available on YouTube, and I'm not going to go into the depth of it. Phacovision is one, Microvis Touch is one, Alcon Fidelis is one. I recently I was able to get my hands on, and where we had a conference on it, only on this simulative training. And you won't believe, for 2 days we had 54 registrations, and 20 minutes we kept one slot, and there was so much of crowd. People did not want to listen to lectures, whereas they were very, very actively willing to participate in these kind of modules, in these kind of learnings, because that is what I really felt when we did one in Trichy last month under YOSI. And I think this is a very, very promising. I'm just finishing on time. So Help Me See is also there, and I'm not going into the other simulators. So the studies are very promising. Literature shows from 2011 to 2023, the meta-analysis all comes to one conclusion. It enhances learning, improves safety, skills are improving, especially for CCC, continuous curvilinear capsular access, shortens the operating time, increases the confidence, and transforms the whole way we understood the whole spectrum of learning. So these are my references, but most of the work that I showed were actually mine. I wanted to keep it most of my work, and I just touched upon the names of the work which is available in the market. So I am Dr. Prasanna Venkatesh Ramesh. You can catch me here on Instagram, mail, or on WhatsApp as well. Thank you, Venkatesh sir. I would have not been the same in innovations if not for you, and if not for my Pondicherry journey. Thank you, sir.